Hello, everyone. My name is Jubril Babatunde. Just ignore Emmanuel Oladeji you've seen there. I'm just using I'm deputizing for him. So I'm welcoming you to this teaching session, the assessment and management of hip fractures or proximal femoral fractures. And today, the speaker will be Mr. Deepak Menon. He's a trauma and orthopedic S23 registrar at the Royal Shrewsbury Hospital currently. And for the next 30 or so minutes, it will be taking us through this management of this very important condition that happens, that is very common in the UK. And hope you enjoy the teaching session. Deepak, over to you whenever you're ready.
Thanks very much. Can you see me?
Yes, we can. And we can see your slide too.
Very good. Hello, everyone. I'm Deepak. As Jubril mentioned, I'm a trauma orthopedic ST3 registrar on the Oswestry stroke rotation. Started on Royal Shrewsbury Hospital in August. And I'm also an academic clinical fellow, so part of my clinical time is spent undertaking some research. Thank you very much for inviting me to this session to talk on proximal femur fractures. I can't see the chat, so if anyone does have any questions, just drop it in the chat. I'll be happy to answer it at any time. So it won't be too long a session. It'll just be going over the initial assessment of this injury, a little bit of pathology, mainly relating to blood supply of the femoral head, which is extremely important in dictating the management of these conditions. We'll just discuss classification, definitive management, and just go through how to perform briefly a hip screw fixation, just in case anyone asks or you haven't seen it before. So obviously proximal femur fractures is a really, really important topic. Yes, it is a reasonably basic topic in terms of orthopedic knowledge, but that's, I suppose, because it contributes such a significant burden of disease, and we see it all the time. A lot of our referrals are neck of femur or proximal femur fractures, and in the UK, the incidence is approximately 65,000 a year. And so this is why it's such an important topic to go through, to understand well. And I thought I'd just spend a little bit of time going through some of the basics that I hope you take home even one or 2 points that might make a difference to your sort of day-to-day practice in the management. So this is obviously a typical X-ray that we see often multiple times a day. So this patient has a left intracapsular neck of femur fracture. And I think it's important to recognize that this injury pattern is bimodal in its distribution, i.e. there are two peaks of incidence. So the first peak is at a very young age or a younger age, and this is typically due to a high mechanism of injury. So we see these all the time in road traffic accidents or high trauma accidents. The second peak is obviously at an older, at a more elderly or older, in an older age group, and typically this is seen with a low mechanism of injury, a fall from standing height, a trip, and so that leads to these neck of femur fractures in the elderly population. So just going through the initial management. So I think it's important to mention that where there's any mechanism of trauma or you're suspicious of trauma, you always have to apply the ATLS principles, going through a primary survey in an A to E approach, identify and treat any life or limb-threatening injuries, and this would be followed by a secondary survey. Following the stabilization of the patient from an ATLS principle, we can then move on to the history. So it's important to identify the mechanism of injury, i.e. how it happened, the date and time of when it happened, and also the date of their presentation of ED, which is important, and I'll discuss in a minute why that is. It's important to identify their past medical history, and notably whether they're on any anticoagulation, insulin, or steroids. It's also important to identify if they have any history of cancer and or whether they're on any active cancer therapy, so chemotherapy, radiotherapy, either currently or in the past. It's important to identify their social history. So I always ask about, how do you mobilize at home? What's your living situation? Do you live with anyone? Do you have carers? I always ask, who does your shopping for you, to identify their level of dependence. And it's important to identify whether they're from a house with stairs, whether they live in a bungalow, whether they're from a residential home, their care home. And it's important to go through or get an idea of their cognition, and we typically use the AMTS for this. We can then move on to our examination. So if we're happy that this is an isolated injury with no other injuries, then we have to make sure this is a neurovascularly intact injury, and most of the time it is. And I typically ask them whether they can straight leg raise, because if they can't straight leg raise, then you have quite a high clinical suspicion, along with your history, along with your examination findings. Typically the limb's short and externally rotated as well. Investigations wise, obviously we need radiographs. We take an AP of the pelvis, we take a lateral of the affected hip. If there's any history of cancer, if there's any suspicion that it's a pathological fracture, or if the fracture extends below the lesser trochanter, or if you're planning on using an intramedullary device, as we'll see, for fixation, then we always have to take a full-length femur. So that means an X-ray of the rest of the femur. If they've got a high index of suspicion, but there's nothing on the X-ray, so if you've got a clear mechanism of injury, the patient's in pain, they're unable to straight leg raise, but you can't see anything on the X-ray, they've still got ongoing groin or hip pain, then the gold standard is an MRI, but typically we request a CT just because it's the easier investigation to get, and that would typically confirm a diagnosis for you if you've got a high clinical index of suspicion. So we also have to be holistic and recognize that it's not just a fracture, but it's a patient that we're treating. So we have to ensure we get a chest X-ray typically we get a chest X-ray to exclude any sources of infection. Also quite useful as a baseline in case individuals become unwell during their inpatient stay. We request an ECG, and we do a routine panel of bloods, which include, alongside FBC for the hemoglobin, using these for the renal function. We also like to request a bone profile, coagulation screen, and group and saves, because most of these patients will have operative management. I've just put here a best practice tariff and Nottingham hip score. So these are things I find quite useful. So the Nottingham hip score is something people don't use that much, but it's essentially a score that uses things like age, sex, hemoglobin on admission, and comorbidities to essentially, you put it all into this calculator online. It calculates the patient's 30-day mortality rate, and it's a really useful score if you need to discuss with family about the actual morbidity of this disease. And I find it really useful because it essentially signifies to both patients and family members that actually this is a significant event with a high mortality and morbidity rate. The best practice tariff is essentially used in the UK, and it incentivizes trusts to essentially improve the quality of care for these patients. So basically, trusts in the UK are paid if they meet certain criteria. So that's if patients are operated within 36 hours of being admitted from A&E. They're paid if they're reviewed by an orthogeriatrician within 72 hours of their admission. They're paid if we document their AMTS score, i.e. their cognition before their operation, and if the physiotherapists review and mobilize the patient either on the day of or the day after. There's also some additional criteria, things like calculating bone health and nutritional assessment that forms part of this best practice tariff. So just in case someone asks you about it, or just in case you're wondering why we need to do things like AMTS and why it's so important to document all of these things. It's actually another reason beside patient care is because actually trusts are actually paid for us doing these things. And obviously it's important to make sure patients are, receive appropriate analgesia. We typically undertake fascia iliaca blocks, and it's important that they're fluid resuscitated, because not only do they lose blood from their fracture, but they're going to be nil by mouth preoperatively. I've kind of mentioned this, but most of them are treated operatively unless patients are deemed not fit enough to survive the anaesthetic. And I've also mentioned about the best practice tariff. We try and advocate surgery within 36 hours of admission to ED, and we try and take that into consideration when planning our surgical lists. So just about blood supply to the femoral head. Pathology, it's a bit dry, but the blood supply to the femoral head is really important. Something you'll always get asked on, or someone was always going to ask you this in the future, and because it essentially dictates the management of this condition. So the predominant blood supply to the femoral head comes off the profunda femoris. You've got two vessels. You've got the medial circumflex femoral artery, and you've got the lateral circumflex femoral artery. The majority of the blood supply is via the medial circumflex femoral artery. It pierces the capsule at its attachment at the intertrochanteric line. It forms these retinacular arteries that travel up the femoral neck into the head. So if you break the femur at the neck, you break the retinacular arteries, you break and disrupt the blood supply to the femoral head, and you get osteonecrosis. And so we can actually classify, based on this blood supply, fractures into intracapsular and extracapsular fractures that I'm sure you're aware of, i.e. whether they occur in the capsule or within the capsule or out of the capsule. And the capsule attaches, as we know, to the intertrochanteric line, the line between the lesser trochanter and the greater trochanter, anteriorly, and to the intertrochanteric crest posteriorly. So taking this a bit further, before I do that, these are examples of intracapsular fractures. So we saw this one earlier on the left of the screen, and then an extracapsular fractures on the right. So that's just breaking just outside of that capsular attachment to the intertrochanteric line. So if someone asks you what kind of neck of femur, proximal femur fracture it is, you can just say this is either an intra or extracapsular fracture based on its morphology in relation to that line. So we can take this a bit further, just because classification of this injury is so important in terms of dictating the management. So this is the AO classification, breaking the injury down into three things: type A, type B, type C. So type A are these extracapsular fractures, type B are these intracapsular fractures, and type C are fractures of the femoral head that we're just going to ignore for now. We're just going to focus on type A, type B. So type A fractures is these extracapsular fractures. They occur within about 5 centimeters distal, so they're all within 5 centimeters of the lesser trochanter. So we can see this example on the right. So this is on the left. So this is a type A1. So that means it's a simple pertrochanteric fracture, which means it's the lateral cortex is preserved, and these can typically be managed with these sliding hip screw devices. So i.e. a DHS, which we can see on the right. Though if we consider them unstable, i.e. if we've got loss of the medial calcar or the medial buttress, then we can consider these unstable, and there is an argument that you could use an intramedullary nail device to fix these fractures. But typically these A1 simple intertrochanteric fractures or pertrochanteric fractures with no lateral wall involvement are managed with the DHS fixation. A2 fractures are a bit more complex, and you can see that there are slightly more fragments. There's involvement of the lateral wall or the lateral cortex, and these are unstable fractures, and they're typically managed with an intramedullary device. Having said that, again, there is an argument for using a sliding hip screw or a DHS device to fix these fractures. And that is kind of a surgical preference, really. Just the advantage of using an intramedullary nail is that you've kind of got a shorter lever arm, as you can see, between the tip of the screw and the device itself, increasing the stability of this device. And then A3 fractures are these reverse oblique fractures. So typically we've seen these fracture lines extending from the lesser troch to the greater troch, and reverse oblique fractures essentially go the other way. And that's you can see here. So if you just put in a DHS here, well, it's not going to work because it's just going to all collapse. So we typically manage these using an intramedullary nail fixation device, as we can see on the right. So those are extracapsular fractures. So I hope now you understand that if you see a fracture line that's out of the capsule, then that's an extracapsular fracture. These are typically managed with fixation, and you can either use a DHS or an intramedullary nail, depending on the fracture pattern. The AO classification essentially classifies this, and we can use that to dictate management. All right. So then you move on to these B-type fractures, which is essentially a fracture of the true anatomical neck. So basically that means that these are these true neck of femur fractures that we talk about. So you've got this B1, which is subcapital, just below the femoral, the head. This B2 is transcervical, the transcervical, never know how to say it. That goes through the femoral neck, and B3 is basicervical, so just at that junction between the neck and the shaft. And the treatment for these is determined really by the age of the patient, the comorbidities, and the function of the patient. Which is kind of why the history is so important and why we sort of go on about it in the trauma meetings. So in the older patient age group with these intracapsular fractures, just remember that the blood supply to the femoral head is essentially gone. You've disrupted them. So if the fracture is displaced, we can't really fix them. So we have to replace the head, and that's why we treat it with either a hemiarthroplasty or a total hip replacement. And the NICE guidance in the UK states that those who can mobilize with one stick or better, who are not cognitively impaired and are medically fit enough for an anesthetic, are best managed with a total hip replacement. So in the elderly patients, however, with what we say an undisplaced fracture, where essentially there's no real displacement, so I'd probably consider this an undisplaced fracture on the left. Then actually there is an argument for fixing the fracture rather than replacing it with a hemiarthroplasty or a total hip replacement. And that's, I'll show you a picture of it, but that's either in the form of a two-hole dynamic hip screw or cannulated screw fixation with just screws that essentially pin the head and the neck together. The main aim is to facilitate immediate weight bearing in the older patient group. In the younger patient group, however, the priority is different. We don't want to replace the femoral head, because if we essentially do that, then there's a high risk of dislocation, but also, remember, total hip replacements can lead to wear, and we need revision surgery in the future, which comes with significant risks. And so even in displaced fractures in younger patients, we reduce these and we opt for internal fixation with these screws. So what does that look like? Well, on the left, that's a hemiarthroplasty. In the middle, that's an example of a total hip replacement. And on the right are these examples of these cannulated screws. You can also use DHS's dynamic hip screws with just a two-hole plate to fix these fractures, really. That's kind of it for management. So it's pretty reasonably straightforward in my opinion. You have to treat the patient as in a holistic way. It's important to ensure that this is a isolated injury, ensure ATLS principles are carried out, manage the patient as per BPT and NICE guidance. That involves analgesia, fluid resuscitation, ECG, chest x-ray, bloods, nil by mouth, and consent and mark them for an appropriate procedure. It's important to discuss with the family and next of kin as well regarding what's happened and about sealing of care as well, i.e. whether resuscitation would be appropriate or not for these patients. And I was thinking about what else might be important to know about. Well, I thought, why not just talk through what actually a DHS fixation involves from a surgery point of view. I'm not sure how many people have seen it, but it's sort of what you start. It's a very common procedure. So the patients, after they're optimized for surgery, are put on this traction table. They're anesthetized, either using a spinal or general anesthetic. They're put on traction, and the foot is secured in this sort of foot holder with tape, and traction is applied. And the reason we apply traction is so that we could reduce the fracture on table, as we can see on the right. The contralateral leg is put into this almost like lithotomy position in a boot, and patients are given IV antibiotics and tranexamic acid as well. In general, we use fluoroscopy as well during the operation to get these images to ensure the fracture is reduced and to ensure our instruments and wires are in an appropriate position. So once the patient's appropriately set up, anesthetized, and the fractures are satisfactory is reduced, we then prep the patient, drape them as standard, and make an incision. It's a direct lateral approach to the femur. I generally mark out where the lesser trochanter is using fluoroscopy. It's about 10 centimeter incision, just above the lesser trochanter down the shaft of the femur. You go through skin, you go through subcutaneous tissue, you identify fascia, and you cut the fascia lata. You then go through you can either use a vastus splitting or a vastus lifting approach. I would use vastus splitting. Identify the femoral shaft and clear it. And then on your right, you can see on your right of the screen, you can see a guide wire. So you put the guide wire into the head of the femur. So the guide wire position is crucial. It needs to be on the AP and lateral view in the center of the head. There's a paper by Baumgartner in 1985 that essentially says that the sum of the distance between the tip of the femoral head and the tip of the screw should be less than 25 millimeters as a sum of both the AP and the lateral views. So once the guide wire is in an appropriate position, you can then measure what length you take the screw at, and you use this instrument at the bottom, which is a triple reamer, to ream out the cortex and going into the femoral head. It's called a triple reamer because you have to have you ream out the cortex, and you ream it out for the threads of the screws, the barrel of the barrel of the screw, and then the junction between the barrel and the plate itself. So these are the threads of the screws, and this is the screw, this is the barrel of the plate, and this is the junction. And that's why it's called a triple reamer. So you ream out the cortex to facilitate you putting the screw in. So you literally just screw the screw in. You put the barrel and the plate over the screw, and then you just fix the screw with typically 4 holes, although you can use longer if there's, for example, a subtrochanteric extension. And that's it, really. And then you wash and close. So that's kind of my summary of assessment and basic management of this injury. Pretty brief, but I hope to the point, and I hope it's So that's my thought process and how I think when I sort of see these patients, which happens very, very frequently on the shift. Does anyone have any questions at all?
Thank you, Deepak. I think we'll give them a few minutes to see if there's any question. But judging by the presentation, I think you have either confused everyone, or you have you have been so thorough with your presentation that everyone understands what you've said. I think I'll go with the latter one. It's a very nice presentation. Thank you for that. I'm guessing there's no question. So what do you think? I think this is a good place to end the presentation.
Yeah, I think so. I mean, if there's any questions, feel free to email me. My email is deepak.menon@nhs.net, whether on this topic or on if anyone has any other questions. I mean, I guess just to summarize the key points, I suppose, because this topic is, comes up not only in clinical practice very commonly, but also, in things like interviews and, clinical, whenever, in any kind of clinical interview at any stage really, whether it's at FRCS, whether it's at registrar, whether at core training or foundation level or medical school level, it comes out at every stage. So it's such an important topic just to get your head around. It's pretty straightforward in terms of understanding. Once you get your head around and classifying these fractures in intracapsular and extracapsular, understanding the management principles is pretty easy. It's pretty straightforward. There is a lot of variation in practice, I would say, about particularly extracapsular fractures, when to use DHSs, when to use nails, and that's that. So I suppose that's an area of often controversy. But as long as you have your own structure and thought process for justifying what you want to do, that's fine. And these injuries can occur in people as young as 15, 16. I've seen it in a patient who's, I think they were 15, 16 years old. And, those can be quite challenging to manage, because with those, you want to take them to theatre as soon as possible, because any delay can lead to avascular necrosis of the femoral head, because as we said before, it was an intracapsular fracture in a young patient. You want to preserve the femoral head, so you want to fix the fracture, but any delay will lead to an increased risk of avascular necrosis. So we used to take them to theatre overnight, but now we take them under the priority on the next available morning list. So these can be quite challenging to manage. The other thing I didn't mention was this: there's if the fracture line extends below the level of the lesser trochanter, this is subtrochanteric fracture, and these are, can be quite challenging to manage, because they're very unstable. So if you see a fracture below the level of the lesser trochanter, these are unstable fractures, because you've got the pull of the iliac psoas, which attaches to the lesser trochanter, flexing up that proximal segment. So these are typically managed with intramedullary devices, but the challenge is in reducing these fractures on table. So that's just another thing to be mindful of. But from a sort of day-to-day point of view, it's about ATLS, history, social history, ECG, bloods, fascial echo block, IV fluids, making sure they're optimized for theatre with orthogeriatric input, and then deciding upon an appropriate management plan and discussing with family as well.
All right. Thank you very much for a very nice session. We'll call on you next time we have another interesting session to present. Okay. At this juncture, I think we'll be ending the session now, and you get a feedback to give feedback about this teaching session to get certificates. Thank you, everyone. Thank you, Deepak.
No problem. Thank you very much for inviting.
All right. Bye.